Today we're going to discuss thyroid gland disorders. Thyroid gland produces thyroxine and thyronine, T3, T4. T4 is found in abundance in body, has larger quantity or larger amount in body. T3 is the active form. In periphery or in blood, T4 gets converted to T3 by deiodinase enzyme, which takes out one substrate from it and makes it triiodo, one iodine from it, and it becomes triiodothyronine instead of thyroxine. And then the active one starts functioning or working. Thyroid gland or thyroid hormones, they have a broad metabolic effects. They affect the metabolism of lipids, fats, muscles, protein. They also increase body temperature or maintain body temperature. There is no slides, it's just a whiteboard, Dr. Mabua. Now, thyroid disorders basically are hypo and hyperthyroidism. Hypothyroidism, and then we have euthyroid or sick euthyroid syndrome. Hypothyroidism, T3, T4 are low, TSH in compensation will go high. We use TSH as a primary marker of thyroid disorders, hypo and hypothyroidism. If TSH is low or high, this points towards either hypothyroidism or hyperthyroidism. Low TSH means hyperthyroidism, or T3, T4 are high in amount or quantity in the circulation, so TSH will come down. Sick euthyroid, in this case, T3, T4, they may be low, but it's only during acute illnesses, and we do not start treatment during this time. We wait and see if there is any problem after the patient recovers from the illnesses. I think we have another T3T form that we can check during sicknesses to differentiate it from hypothyroidism. Now, hypothyroidism and hyperthyroidism, they both can be either symptomatic. If they are symptomatic, they require treatment, or subclinical. Subclinical hypothyroidism means patient has high TSH, but no symptoms. Now, normally, if TSH is high and they're not symptomatic, we don't know RX unless TSH is above 10 or patient has either gets pregnant or has another concern that we need to treat the low thyroid in that situation. Other than that, we do not treat subclinical hypothyroidism. Symptomatic hypothyroidism, like patient with weight gain, cold intolerance, patient with dry skin, and many more symptoms of hypothyroidism, bradycardia, etc. Any of these symptoms, if patient is symptomatic with symptoms of hypothyroidism, we would treat them with medication. Medicine is levothyroxine. Usually we start lowest dose and then titrate it up till patient becomes euthyroid. Now, some conditions, some patients, like those who are elderly and those who are cardiac patients, in these two groups, we titrate very slow and we start really low, titrate very slow, making sure they do not become symptomatic for hyperthyroidism, or we do not overcorrect hypothyroidism. Moving on to hyperthyroidism. Now, hyperthyroidism, in this case, T3 or T4 or both, they will be high. And in compensation, you will see that TSH is less or low. So low TSH with high T3, T4, this means person has hyperthyroidism. Common type of hyperthyroidism is Graves' disease, in which you have thyrotropin antibodies or TSH-like antibodies that stimulate the secretion of thyroxine, TSH receptor antibodies, TSH receptor antibodies. So these antibodies, they stimulate production of thyroid by binding to TSH receptors on the thyroid gland. And this is how they cause hyperthyroidism. Hyperthyroidism, again, in some cases, you may see that TSH is slightly low and T3, T4 are slightly high, but no symptoms. So we can say this is either subclinical hyperthyroidism or it is thyroiditis that's presenting as hyperthyroidism, and then it's going to go to hypothyroidism. These usually do not require treatment. But if patient has symptoms like tachycardia, heat intolerance, weight loss, atrial fibrillation, any of the symptoms of hyperthyroidism, in that case, we will start treatment. Rx is needed. Now, treatment for hyperthyroidism is so treatment is two types. One is for symptoms, and one is to control secretion or control the reduce the level of T3, T4. And finally, we have definitive treatments. Now, symptomatic control. So hyperthyroidism mostly causes sympathetic type symptoms like tachycardia, fibrillation, palpitations, sweating, etc. We can control symptoms with propranolol or beta blockers, especially during a thyroid storm, which is a sudden surge of thyroid hormones due to surgery, acute illness, etc., in patients with overt hyperthyroidism. For reducing the secretion or T3, T4 levels in the body, we use propylthiouracil, methimazole, and carbimazole. These are the medications we can use. Now, propylthiouracil, this is preferred in pregnancy, first trimester. Methimazole is the drug of choice for others. And another indication for propylthiouracil is during thyroid storm. So propylthiouracil, it not only works on the thyroid gland, it also reduces peripheral T4 to T3 conversion. And definitive treatment of hyperthyroidism usually involves radioiodine ablation that we do not do in patients with Graves. Thyroidectomy is another option. If they have an overactive nodule or a lump that is causing the secretion, then we can do lumpectomy or partial thyroidectomy. These are some of the options for permanently reducing the levels of thyroid in patients who have hyperthyroidism. After hypo and hyperthyroidism was a quick overview. Causes of hypo, usually autoimmune like Hashimoto's, postpartum or peripartum thyroiditis, subacute thyroiditis or decurrence thyroiditis that occurs as a response to infections. The only difference in these is that in decurrent, the thyroid will be painful and tender. The other ones are usually painless thyroiditis. All right. Other than that, we have cancers or malignancies of the thyroid. Malignancies are papillary, medullary thyroid cancers, and then anaplastic and follicular cell. So papillary thyroid cancers, these are most common and they have the best prognosis. They have good overall survival. Anaplastic is seen in elderly patients. These are highly aggressive and they make about 1% cases of thyroid cancer. And these have a very bad prognosis. They quickly spread and cause deaths. Medullary thyroid carcinoma, these are usually seen in people with men 2A and 2B syndromes or multiple endocrine neoplasias. Follicular thyroid carcinomas, these are calcitonin secreting tumors because they are affecting the follicular cells, which are responsible for secreting calcitonin. Calcitonin causes the calcium to be deposited into bones, so this will present with hypocalcemia. This was a quick overview of thyroid gland disorders. These are some of the high yield topics that we need to know in thyroid gland. I hope it helps. And now we can start our MCQs.